would you like to address the questions and then come back to Dominique for any questions to Dan, and then we close?
Thank you, Katerina. The first question is to Dr. Poletti. I don't see him. Is he around?
No, he's not, because he had to go, but
Okay.
if you have any questions, I think we have a lot of sarcoid experts around, and Dan Calver was in the diagnostic guideline.
Good. Okay.
So
there are two questions. Will you take them, Dr. Calver?
Yes.
Sure.
Okay. So the first one is, given that in the area of COVID, acute heart complications may arise, do you think it is reasonable to reconsider the current recommendations in the near future? This was a question by the audience.
The diagnostic guideline recommendations and how does that play out in the era of COVID?
Yes.
Well, I think the concern to me is that you want to minimize exposure of patients and of healthcare providers to potential risks. And so if you're faced with a patient who potentially has sarcoidosis, my bias and what we've done in our institution is only to pursue a diagnosis if there's an urgency to establish it immediately. I would rather try to defer or delay the diagnosis for a while until things are under better control, unless I need to make the diagnosis right away. And there's lots of situations you can think of where it wouldn't be so bad to delay the diagnosis a bit.
Yes, I think this is very logical. I've got another question for you. Do you think that by assessing only serum calcium and ignoring 24-hour urine calcium, do we miss significant hypercalciuria in a number of patients?
I think that's a very good question, and I can tell you there was a good bit of debate on the guideline committee about things like that. I think that hypercalciuria is about 3 times more common than hypercalcemia.
Exactly.
And we know that's a risk for renal lithiasis and renal insufficiency. One of the difficulties with a guideline like this is that the rigor which the methodologists want to approach it is to only base things on very strict evidence. So something like hypercalciuria, which has much less evidence, didn't find its way into the guideline. But I think that it's not unreasonable to do that on a routine basis, especially for somebody who has any history of a renal stone, for example.
Thank you. The other question is about searching for a heart disease in sarcoidosis patients. There seems to be a quite big difference in the ratios of patients with cardiac sarcoidosis, say between Japan and Western Europe. Should we follow the same guidelines everywhere when there's such a big difference in the commonality of the disease?
Yeah, I think in Japan that the guidelines may be not quite as valid. Of course, there are not a lot of data about the appropriate way to screen. There was and Athol should probably jump in here, but Vasilis Karanos did a study looking at patients with no symptoms to suggest cardiac sarcoidosis and looking at the incremental benefit of the tests we might commonly do, like EKG or echocardiogram, and found very little benefit to those things. We know that there is a lot of asymptomatic cardiac sarcoidosis, probably 5-fold the number that are asymptomatic versus the ones that develop problems. And so my personal belief is that doing an EKG and asking closely about symptoms and then having a very low threshold to investigate symptoms aggressively.
By MRI.
That's how I do it. But there are certainly others who feel more aggressive about screening routinely, including some who would even argue that there should be routine MRIs. I think the risk of that is finding a lot of asymptomatic, clinically non-bothersome disease that then drives additional testing, unnecessary therapy, and interventions that may hurt patients. So I don't like that, but we don't know for sure.
Thank you very much, Dr. Calver.
I might just add one comment quickly, since Dan invited me to. A major issue that we've stumbled across is that if you think you're screening using symptoms, but you have significant interstitial lung disease, that will mask what might be cardiac dyspnea. And I have a string of patients now where this algorithm simply would not have picked up cardiac sarcoid, but they have major cardiac sarcoid, and the hallmark has been elevation of BNP.
So you would be more proactive in searching for cardiac sarcoidosis in patients without taking in consideration symptoms?
Oh, I take them into account if they're there, but if you have dyspnea due to lung disease, it's terribly difficult to find that you've got a symptom suggestive of cardiac dyspnea, and this is quite a common scenario, and this really bothers me about this algorithm. Secondly, BNP is cheap, it's easy. Of course, it needs to be validated in larger populations, but you see so many tragic patients downstream where this is missed and they're left with major cardiac impairment at high risk for mortality. Look, I can understand in a guideline you've got to go on the existing evidence, but the problem might be that we are stuck with this algorithm now for another 10 years until the guideline is rewritten.
Okay, thank you very much, Dr. Wells. Shall I go on with Professor Tomasetti?
Yes, Marina, go on.
Thank you very much for your talk, Dr. Tomasetti. Could you please tell us a bit about how you imagine the future of interventional pneumonology in the COVID or after the COVID era? What is going to change and how?
Well, what is going to change is the way we are performing procedure and the way we are cleaning the endoscopy rooms and circulating air system after each patient. So endoscopy activity will inevitably slow down, has inevitably already slowed down, given to the policies related to the sanification of the endoscopy room, and we are using more accurate personal protection devices for all cases, and I think this will remain permanently unless until we will not have an effective vaccine and the risk of COVID will be completely defeated.
Thank you. What was the most difficult aspect of interventional pneumonology during the pandemic in your institute?
Well, the most difficult part was to set up the dedicated negative pressure room, which is actually, I think, in many hospitals has been easy to set up, but in some environment probably was not so easy. So we basically found a solution using the OR rooms, and we used one dedicated OR room for the COVID infection. And the other difficulties is to perform rigid bronchoscopy because it is discouraged by current interventional pulmonology guidelines because it is a very high risk procedure given the direct exposure of the endoscopist.
Thank you very much. Do you think interventional procedures will slow down, or some of them will be made obsolete? Not really, but just for practical purposes until a vaccine is developed?
I think we will reorganize our services a little, but probably I'm observing that doing bronchoscopy takes more time for each patient, but we can reorganize the services with longer working hour, including the afternoons, and hopefully with more personnel and more endoscopy rooms, we will overcome these obstacles. So
this is such a nice answer. Thank you very much. And now we come to Dr. Wells. Dr. Wells?
Sorry, you're not coming to me, I don't think. I didn't have my hand up.
Okay, but I have to ask you some questions, Dr. Wells.
Okay, fire away.
Okay, so the first question is, how do you find nintedanib tolerated by the patients with CTD-ILD, especially scleroderma?
Yes, I didn't present those data, but it's absolutely identically tolerated in that subgroup to the other subgroups, full stop.
Okay.
Yes, I might have expected there would be more trouble with GI side effects. The answer is there is not. And that's actually set out in the Lancet Respiratory paper, which must have appeared, I guess, about 2 months ago.
Okay. Would you continue immunosuppressive treatment in these patients, in the CTD-ILD patients?
Yes, I would, because I think we're in a situation, you've got to, first of all, as always, find the minimum therapy you need. That's an excellent principle across the various diseases we treat. And if COVID triggers you doing that, that's a very good thing. But I think based on the steroid data we've heard and a belief that there may be a big difference between low and high dose steroid in sarcoidosis or elsewhere in terms of risk from the virus, I'm not sure that I would be obsessive in trying to withdraw steroid. So whilst it seems like a very good thing, if you're on a prednisolone dose of, say, 20 or 25 milligrams daily, to find out fairly quickly whether you can get down to 10 milligrams a day, I think at that point I start to become worried that you might be removing a protection with low-dose steroid therapy. And the problem is people lump steroid doses and just talk about giving steroid.
Okay.
So personally, I would not. I would find the minimum dose I would want to use in various treatments, but I wouldn't actually push my luck and go down to under treatment.
Okay. How about the rest of immunosuppressive treatment, like rituximab, azathioprine, and so on?
Well, I don't think we can possibly yet have a feel for that.
Okay, so
I mean, there are two things we need to find out. There's this anecdotal sense emerging that our various interstitial disorders seem to be very strangely protected against severe COVID infection. They ought to be hugely vulnerable. They've got the comorbidities. IPF patients are an older age. They're starting with a major reduction in respiratory reserve. They're ticking every box for should do badly. But the uniform observation is that this isn't the case. Now, maybe the mechanisms in these diseases tie up pathways that would be damaging in COVID, who knows? But it might also be that the therapies across the board, if used in moderation, actually switch off key early auto-inflammatory pathways in COVID. We just don't know the answer to these things, and I don't think we can start to discriminate between individual treatments. And there's a danger of being over theoretical at this stage and trying to do that.
The question was, apart from COVID disease, I mean, if we didn't have any COVID around, would you continue on the CTD-ILD patients, both drugs, both immunosuppressants?
Different questions. I was obsessed with COVID. Look, I think you've got to make a case-by-case judgment of that, because we present failure of therapy as if it's a totally yes-no option. There are certainly patients that are progressing more slowly, where you believe that the treatments you use may be partially effective. And then again, we do know already that in the census study, combining mycophenolate and nintedanib had no adverse profile. So my bias is to cover both pathways where you have immune dysregulation to treat for both. This is totally non-evidence-based. Everyone must make their own judgment about that. But my fear is failure to take an opportunity rather than over-treatment.
Do you think that in the future, the indication for antifibrotics in CTD-ILD will be larger, and not only to the patients who deteriorate rapidly?
Oh, I think we have a pathway for those patients that progress despite therapy, and I don't think the data are saying that this must happen rapidly. So I think already, so for example, for the study, it was progression over the 2 years before enrollment, not over the 6 months. And so I think we're already on that pathway. Yes. The trick will be to find the patients who are going to fail therapy before they've failed therapy. And that's what we urgently need. Biomarkers of some kind.
Do you have any idea of these biomarkers? This was my last question.
Well, no, there are candidates, are there not? And one suspects that it'll be early change in biomarker rather than early baseline biomarker, because we're stuck with the same problem as always with single point of time biomarkers. Are they epiphenomenon suggesting that are reflecting damage that already exists? Or are they driving progression pathways? So I think you will want to see validation that early treatment, where you have immune dysregulation, is or is not switching off biomarkers, with this predicting those patients that go on to progress despite treatment. It's a great goal, isn't it, to get a blood test at the start that gives you the answer. But I think that was a pig I just saw flying past my window. I don't think it will happen.
Thank you very much. Thank you, everybody. Katerina.
Yes, thank you, Katerina. Thank you, Professor Wells. I strongly agree what he said, Professor Wells, regarding the biomarker. At baseline, it is difficult to predict with only one biomarker, but maybe what you've said about the fluctuation and different time points when we have progressed, maybe we could predict. So we are moving versus precision medicine to both ILDs and COVID disease. Any questions from Professor Giannakis to Professor Vasilakopoulos? Or I will ask Leticia regarding anticoagulation. We know that there are some reports and some, let's say, guideline about the use of D-dimers in established or not therapeutic versus preventive anticoagulation. Mainly in severe patients, mainly why? Mainly because in some CTPA are negative, they can't be done because of the severity of the patient, and also because, as you said, histology patterns where microthrombi are difficult, of course, to be seen in CTPA or other imaging. So I would like your comment on that, Leticia.
So I have seen such a discussion, especially on Twitter, some very hot discussions on elevated D-dimers triggering full anticoagulation. That discussion came from some papers from China showing that patients that had the worst outcomes were the ones that were upscaling the D-dimers and had very high levels of D-dimers. It's truly difficult to sort out if D-dimer is only a marker of a coagulative process or whether you should interfere in the coagulation process. I am with the group that has for now the opinion that we should be fully anticoagulating patients when they have traditional indication for. But I completely understand other colleagues that decide at least to do a higher dose of prophylaxis in those cases. We definitely need more evidence, because the fact that we recognize that there are thrombi, small microthrombi going on, doesn't necessarily mean that if we intervene with anticoagulation, that is going to work for the patient as a net result. In the past, for example, if we remember sepsis, the Shigris drug, the C-reactive protein drug, so promising. We see in sepsis also microthrombi, but then when we go treat the patients, the outcomes, the net outcomes are not always good. So that makes me more conservative in this point.
Maybe someone who is working in ICU has a comment on that, because in Crete we lost a patient and then we saw that it was because of microthrombi. So maybe Dan would like to comment on that, because he's working currently in ICU.
I very much agree with being conservative. I think that one thing that we do is a very liberal use of point of care ultrasound to look for thrombi, and we're guided by D-dimer to a degree, but we don't anticoagulate outside of that for any particular reason. I think in critical care medicine, as Letitia pointed out, we have had very many things that look promising that make a biomarker look good, but don't make the patient survive better. And so activated protein C is a good example, tight glucose control. You can go down the line of things that make biomarkers look good, and maybe tocilizumab is the same, right? We can drive things down that we want to measure, but do you make the patient survive? Do you make them walk out of the unit sooner? And I think you have to have well-done randomized controlled trials to change your clinical practice. We've seen that very good, tight critical care management of the basics really results in very, very good outcomes for most patients if your healthcare system's not overwhelmed and you're not over 80.
Thank you, Dan. Professor Kumis would like to comment on that. Your microphone. Unmute microphone, Professor Kumis.
I would like to add something on the top of that. We have to keep in mind that most of these patients having the severe infection with the coronavirus are of advanced age, and they have also hypertension. And so these people are actually in a very high risk of bleeding. So we have actually to be quite conservative if we would like to apply full anticoagulation. I don't oppose to the idea to increase a little bit the dose of preventive anticoagulation, but I don't know if that adds something to the therapeutics. But full anticoagulation is something that sometimes can prove to be disastrous.
Katerina?
Okay, yes, we all agree on that. Professor Giannakis?
I have a question from the audience to the Theodoras. In an ERS webinar on April, some preliminary promising data on the use of anti-CD147 monoclonal antibody named miplazumab for the treatment of critical COVID patients was shown. Do you know if there is any further relevant literature on this issue?
From my knowledge, to the extent of my knowledge, there is nothing published on that. Probably it is something, a trial that has been presented in a preliminary form. In fact, there are a lot of trials that we're waiting. Every 10 days, we are going to learn more.
Professor,
I'm not aware of anything on that. I don't know if anyone is...
I think it was a small study, I think 17 to 20 patients that gave some promising results on recovery, but it's very small, and I think not so powered to address this issue. Okay.
I would like to ask Professor Vasilakopoulos his opinion about repurposing drugs versus new drugs, more targeted ones, and versus cocktail drugs. As we have seen, different phases of the disease, different clinical phenotypes. So as I know that you have extended knowledge of the literature, I would like your opinion about that. For example, regarding a drug like what we have for H1N1, for example, this promising study from Emory University regarding a tablet given orally. What is your opinion?
Well, generally speaking, the experience of the medical community on drug repurposing is not very successful. I think the best example of successful repurposing is Viagra, but for another reason. So
good.
I'm not very optimistic that drugs that are designed for one disease will be really very effective in this particular disease. Of course, when you have nothing else, you go and try everything. And there are diseases like infectious diseases, viruses, like the influenza virus. We're having some drugs, and we're having also a vaccine, and still people die out of influenza. So the hope that is around the community, not the medical community, but in the lay public, that there will be a magical drug that you are going to receive and the whole thing will be over, is very optimistic to my point of view. Of course, a vaccine, especially a successful vaccine, would be the solution. But this is more likely to come than a real specific drug given for that disease. This is my understanding of the literature.
Thank you. Are there any questions, Dominique, for Dan regarding vaccines? No?
No, listen, I didn't get any question for Dan, but do we have time to ask him one question?
Yes, and then we close.
So first of all, Dan, I wanted to congratulate you for this excellent talk about vaccines. And my question is that one. You told us that normally it takes about between 10 and 15 years to get a vaccine available. So how can we speed up the manufacturing of this one in this specific situation? I mean, what are usually the limiting steps to get a vaccine available more rapidly, and that can be overcome in this particular COVID-19 situation? Do you have any answer?
Well, we don't know for sure. Of course, typically the regulators move slowly. There's a lot of de-risking that's happened by agencies like the Center for Epidemiologic Preparedness, CEPI, and by BARDA and by the WHO and others, which have allowed more people to jump in quickly with very little preclinical data. And then, of course, the regulatory agencies are allowing the companies to collapse several of the phases of clinical trials together. You saw a lot of 1/2 or 2/3 trials happening. There are, for example, I can tell you with the Moderna vaccine, which is an mRNA vaccine, the NIH has put together a network of institutions which will pretty quickly enroll 30,000 patients. And so I think bringing that many people together that fast with money behind it allows the process to move much faster. The other thing that's happened both in the US and in Europe has been that there's been de-risking for the manufacturers. And so several of these vaccines are already getting manufactured as we speak. We don't know if they'll be successful, but we're betting on the chance of them being successful and thinking that it's worth that bet if they are successful so that we can be that much further ahead. And so all those things, I think, are usually quite long delays, but I think right now there's a lot of momentum and we've seen in medical editorial that some of this cutting corners is not good, but I think right now we're balancing speed versus rigor a little bit. I think it's important to remember that less than 10% of vaccines that start off in preclinical ever successfully get developed. And so, I think having all of these different efforts moving forward is really good and really important.
Okay, thank you. Are there any questions from the floor? I didn't get anyone, but maybe I missed them. Any question for Dan?
Clear.
Okay.
Yes. I think in the next webinar, or I hope a live event, we will have the vaccine and we will have the trials, and we will have everything after summer, I hope. So I will conclude also on behalf of my co-chairs, Professor Poletti and Dr. Titopoulos, and I would like in particular to thank the Hellenic Society of Chest Diseases, VASONG and ALAT, and all the national societies from Europe and Latin America for being with us. I would like to thank all the moderators, the faculty, because all of them have accepted to do presentations and to happy to moderate. They did that with great enthusiasm from early in the morning in Greece. So I would like also to thank all the participants. We've had a lot of registrations, more than 150 free registrations from Latin America. And I would like to thank particularly Latin America, because I think that is the first webinar, international one, at least in Europe, which included Latin America. Of course, VASONG and Dan and Israel, Dominique for being with us, all of you from Greece, Athens and Thessaloniki, for sharing and participating with great talks. Of course, Afea, Irini, Cleopatra, and Sisi for helping us to coordinate this event, and of course the platform Live Media. And I will say good evening, Saturday evening, and happy weekend to everyone. I wish you to have a COVID-free summertime, and we will come back early September with a virtual ERS Congress. Some of us will be in Munich, but it will be a virtual event. It will be the 30 years of ERS, and already more than 10,000 registrations have been done. So please do that. We will have a very great program for all of you. And I wish you all the best. Stay safe. And thank you so much from the bottom of my lungs. Thank you so much. Have a